my focus, as you will have judged, is on trying to raise people's health literacy as a way of, I'm going to say, balancing the power imbalance between the providers and the individual. So that's the main focus. And we take a economic view. So it's all about the relative payoffs in terms of returns on investment to different choices in how you articulate the system, how you set up incentives. And so you'll become clear as we go through here. I have to go back to first principles. The work that Rima referred to is actually from the American Army Tank Corps, where some reading researchers were able to predict the relative difficulty of tasks and realized it wasn't texts that were difficult, it was what you asked the reader to do with them. Since the original models that explained about 63% of the variance, we're now up to 93, so give me any task and I can tell you without testing anybody what the relative difficulty is. So that let us build really good, efficient assessments, and we did a lot of that, and it made us feel good and paid us a lot of money, but it didn't change the world because you really have to teach people. So we're now in the process of applying that same framework to get much more efficient instruction. Some of you have heard me waving my arms for 35 years. We put our health literacy and literacy and numeracy measures on a 500-point scale. It divides into 5 proficiency levels. Those proficiency levels are linked to underlying cognitive research, so they have some validity. They're also linked to outcomes. That the cut point between level 2 and 3 is what I call the shit happens line. Everybody south of that level are the people that bear the disproportionate burden of almost everything that's bad that can happen to people. Ill health, social exclusion, unemployment, poverty, blah, blah, blah. So we knew that this thing was there, but we didn't know really what underlay the effect. And so the 2 brain pictures are work from the Shawitz's lab. And what we know now is level 1 and 2 are in the back of the brain, use the recall processes that get used to remember anything. So they get used to remember the act of reading, but they also are associated with any craft or procedure that you'll learn. And it isn't until you get to level 3 that you actually move up into the prefrontal cortex and start thinking critically, problem solving, integrating information to generate new information. And so if you have a little step back and you think about what is it that, from the demand level, what the health system places on people, almost all of it's at that level 3 and above. By definition, most health tasks are damnably difficult. So the question is really the fit between the skills that people have to deal with those tasks and the demand. Another little aside here, people below level 3, many of them are still in the process of learning to read technically, so they don't have good fluency and they're not fluid and automatic readers, so more of their energy, literally, because these are glucose uptake, go to the act of reading rather than building meaning. And many of them, by the time they get to the end of the sentence or listening to the doctor, their buffer's full and they got to go back to the beginning because they didn't get it. And so we want to move more people to that prefrontal cortex processing because that makes them independent learners. A little bit of Scott's musings. We have in our work defined, okay, so these skills have a direct impact on all of these outcomes. And in health, we've mused about 3 different pathways. The first one is the absolutely obvious direct one. People with low health literacy just don't have the input channel to take benefit of that information, whether it comes in a pamphlet or from a doctor or a nurse. And so that's bad in and of itself, but what they do, because they have that problem, they turn to unreliable information sources for their advice, because we talked yesterday about the decision processes. People make choices, and many of them make bad choices. They ask their husband or their coworker or the the tabloid newspaper or some such thing for advice about what to do. The second one we call an indirect pathway, where the adults that have low skills are ironically sorted and systematically selected into the most risky, dangerous places. Employment-wise, lifestyle-wise, they don't have income, so they can't buy a gym membership. They don't have income, so they can't buy a healthy diet. And so they have very few prophylactic things to attenuate those risks.
Sorry, Scott, do you mean they're adults with low skill in the indirect pathway?
Yeah.
Okay.
Yeah. So in all of these, there's a gradient, and we think there are some thresholds. And the third one is the one that I've mused about the most but never been able to measure. Because the link between skill and outcomes is so great, it's a pretty easy leap to think that those people are subjected to chronic stress. And there's lots of literature in human populations and in animal populations that creatures that are subjected to stress have impaired immune systems, and you see these links to cardiovascular disease, cancer, diabetes, and earlier death. So a little aside, I didn't put this slide in, but just to put a point on this, people with low health literacy skills are 2.5 times more likely to be in fair or poor health than their more skilled peers, even after you control for 36 variables. So if you're a bad scientist, you go, oh, it's got to be something else. It's their hair color or, where they live. But we've controlled for all of that. So if there is something else, it's something that's completely mysterious and uncorrelated with all of the variables we've removed. So this is a fundamental effect, which leads us to believe, as an article of faith, that if you increase skill, you'd see massive increases in the quality of life of people and reductions in their utilization of health services. I put this one in just, this is, every one of those blue dots is a health region in Canada. The black regression line shows that as health literacy rises, the prevalence rate, in this case of high blood pressure, drops, which is what you'd expect. Same for diabetes. And if you had your path models yesterday, there's lots of covariates under this, but when we take the covariates out, most of the relationships remain. Okay, so that's the outside thing. This matters, and it matters to things that cost the system a lot. This is a little more along Rima's line. We better look at the system itself. This is for 4 key health occupations, the proportion of workers in those occupations that have skills lower than demanded by their occupation and associated with full performance. So you have in Canada 300,000 plus registered nurses, who about 95% of them read at levels lower than what their occupation specification demands. And you can imagine what impact that has on the efficiency and effectiveness of provision. And I know some of you are practitioners here, the big fight about, those nasty LPNs taking our jobs, taking our activities. They're way more proficient and way less likely to have skills lower than their occupation. So it's heal thyself first, Rima, you're absolutely right.
Is that data published?
No, because the Canadian Nurses Association wouldn't publish it after I wrote the paper for them. We can make it in the public domain. Yeah.
Could you repeat that again? Did you say that the reading levels are higher in the LPNs than in the RNs?
Well, no. Okay. So each occupation has a demand level. Nurses are at the highest level, level 5, but most of them are at level 3 or at level 2. LPNs, the demand level is level 3, but most of them meet that demand level. And in Canada, as in the US, I think large numbers of Filipinos.
As an immigrant, I can probably say this. Working in the healthcare field in Canada, there's a significant mix in terms of particularly like Filipinos or prominent nurses. I just wondered, did you examine issues around race and ethnicity? Because you would expect somebody coming from a different healthcare system to have additional problems. I'm an Irish Paddy, but
well,
okay for me to say that.
The uncomfortable answer is that the incidence no, how do I say that? Foreign-born nurses are more likely to have the problem, but the predominant, in absolute terms, the problem is a Canadian-born, Canadian-educated problem.
So I looked at for example, since the requirements for education in nursing changed
Yeah.
in the last few years.
Yeah, you see big effects.
You see the difference?
You see big effects.
You do.
Yeah, yeah. But even that, there's moral and ethical issues. We just did a study with colleges across the country, and many of them included nurses, and to our chagrin, Camosun here in BC, only 2 of the 400 nurses we tested fell below level 3. And that's both good and bad. All they did was change their intake requirements. So those people are in other occupations now, still with low skills.
We are going to have time
Yeah.
for questions and answers after.
Okay,
and
so I'm
Scott
going to
has
go
only
really
4
fast.
minutes
Yeah,
left.
okay. So we're spending a lot of time and effort on what's in the way. Demographics are in the way because there aren't enough kids to change the skill supply, so something needs to happen with adults. Technology tends to amplify skill-based inequalities. We're in a period of labor shortage, so employers are going to hire people who they never would have touched before and have to deal with their skill issues, including, workplace illness and accidents. And our government is in a mess, and they can't afford, because they're paying my pension and my healthcare costs, to spend new money on much of anything. So I have a policy prescription: fix the K-12 system, because 40% of the kids leaving it still have level 1 and 2 skills, which means they won't be fully independent. Do something in the adult population, but get the government to induce employers to pay for most of that. And then for economic reasons, we actually need to increase the economic demand for skill use, because that's the only place where there will be employment left. So our focus, apart from building tools, has been on trying to quantify this for the government. How many people, Canadians in the room, know what we're going to spend on our fighter jets?
45 billion.
45 billion. So for 29 billion, a deal for you, we can fix the adult literacy problem in Canada. So it's a good deal. And the
They're not cool though.
yeah, they're not cool. Yeah. So we've been doing these thought experiments, but using very sophisticated technology to say, okay, so if you did that, what would you get out of it? And the first thing that makes us fall off our chairs is that investment would yield $86, $87 billion in additional labor earnings each and every year downstream. And so you go, that's a bit better rate of return than Canada Savings Bonds or GICs. The same investment would save a lot of money in income support: $330 million in employment insurance, $2.1 billion in social assistance payments per year at the Canada level, and $487 million in workers' compensation. And because you're health practitioners, those last two, social assistance and workers' comp, they're in the health system a lot in terms of both demand and the costs of treatment. So the overall 5-year rate of return on that is 1,390%, which isn't bad. Yeah, almost done. So then people were so intrigued, the Public Health Agency asked us to extend the analysis to look at health expenditures, and just on the 4 big ones, hospital visits, physician costs, dental costs, and eye costs, you can save $1 billion a year if you invested that money. So that just drives up that rate of return. And the only one that goes up is eye costs. People who are more skilled buy more ophthalmologist visits and eye care. I'll skip that. Okay, so now you get the commercial. If you get somebody to invest, you want them to get their money for it. So we've been building on behalf of the Government of Canada, web-based, adaptive, inexpensive, valid, reliable, highly predictive, and something that gives immediate results, web-based tools for the assessment of health literacy. And because you want to do that for 4 different reasons, you want to see if somebody has a problem, and you need to know that very quickly. You want to have a score so you know where about to start somebody in their instruction. You want to know if having given them instruction if you gained, how much skill they gained. And then because of that nurses problem, we have a certification for employment. So those are all examples of the kinds of tests we have, and we put them on the international scale so we can compare them to our trading partners who have the same problem as us. And then I'm going to end with this part because people accuse me, oh, you're just an assessment clown. What we've done is run several large-scale national intervention pilots, the most recent one with the Association of Community Colleges, where we did 20 to 40 hours of focused instruction using those same frameworks we use for assessment, and did a lot of related research around them, tested them on the way out to look at learning gain, and tested them 6 months later. And the happy news is that we gained 27 points on average. So out of 2% of a normal year's education, we get the full value in terms of health literacy of skill gain. Oh, and my dream project. Coming back to that first point about the 3 causal pathways, I want to look at that third one where disadvantage translates into high blood cortisol levels, translates into immune function impairment, translates into disease. Because these linkages are so high, the rates of return would dwarf those ones I put. And then we could actually afford a fleet of jets. So I'm looking for partners for that last bit. Mark?
We're happy to start tomorrow.
Okay.